Righty. So I'm going to talk about CalPEG today, or Calaspargase Pegol, and hopefully by the end of the talk we'll have a better understanding as we switch to this product. So the reason I'm talking about it, obviously, is that it is the new asparaginase product on the market, and we will be starting to use that very, very soon. Okay, now I can't forward my slides. Some reason. Hold on one second. Are you seeing forwarding of slides?
There we go. Yep.
Oh, perfect. Okay, so this slide is just to review the asparaginase formulations that are currently on the market and the ones we use. So they're either based on E. coli bacteria, so they derive the asparaginase from E. coli or from Erwinia chrysanthemi. So they're also either short-acting or long-acting. So I'll just review briefly that the E. coli component, is the drug of choice. So we use E. coli up front. Some of you may remember native E. coli or Kidrolase, which was the initial product that was short-acting and was discontinued a number of years ago due to the fact that it caused so many allergic reactions. And it was replaced by Pegaspargase, or Oncaspar as we all know it, which was a long-acting product that has benefits over that short-acting product that I'll go over shortly. And now Servier, the manufacturer of Pegaspargase, has now switched out to CalPEG, or Calaspargase Pegol, or what they call Asparagase, as the product name. And this is what I call the long-acting product. And it has been approved in Canada. But as you can imagine, Servier doesn't want two products under its portfolio that do the same thing, as they don't make money that way. So they are phasing out the PEG asparaginase, but I will talk about why it will still be used in our patients under the age of 1. And then the Erwinia chrysanthemi, as you all know, is used in patients that have severe reactions to E. coli asparaginase, or who deactivate their drug, which just basically means they don't have enough asparaginase activity or leukemic effect from their E. coli product. And we have Erwinase, which you all know as the short-acting drug of choice originally, which is being now phased out and replaced by Jazz Pharmaceutics as Rylase, which is the recombinant form that has better stability and now is approved and in use in Canada. So what makes an asparaginase product long-acting? So this is just a bit of chemistry here. I won't go into too much detail, but basically the polyethylene glycol component. And as you can see from the diagram here, the top structure is the asparaginase itself. So that's your native E. coli asparaginase, the colorful one. And the one on the bottom has the polyethylene glycol attached to it. And all that is it's basically a polymer. It's made up of monomers, which are, would make it look like that wispy sort of chain-like component around the colorful part of the drug, which is in the middle. And that basically makes it a more stable product, which makes it more long-acting, which is what we're looking for, because we want to maintain that asparagine depletion, which is the activity, of course, of asparaginase, because the asparagine is not produced in leukemic cells. So we want to maintain that asparagine depletion for a longer period of time if possible. And that's what these pegylated products do. So it also makes it more water soluble. And that improves stability in different pHs and temperatures, etc. And then the reason I'm going to talk about the linkers is because that's really the only difference between Pegaspargase and Calaspargase Pegol, is they've changed the linker. So you have this polyethylene glycol protecting your asparaginase. It needs to be linked to the asparaginase, and what they've used is succinylamidyl succinate for Pegaspargase and replace that with succinamidyl carbonate in CalPEG, which causes it to have a stronger reaction. These are esters that link by reacting, bond reacting, that is, that then link that or attach that polyethylene glycol to the asparaginase. And that causes, with the CalPEG, a much tighter bond. And I will go a little bit into the linker in the next slide. But what this really does is protects the asparaginase in the middle there, that colorful bit, from being broken down by proteolytic enzymes in the blood, and so that it lasts longer. And it also, the water solubility makes it less immunogenic, which is definitely a benefit of the, well, we hope is a benefit of these pegylated products. So this you've probably seen, some of you. I'm just going to go over the pharmacokinetics just very briefly here. And so I've talked about the linker. CalPEG has a stronger bond produced by its linker, which now renders it with a longer half-life and a longer duration of activity. So now we're tripling our half-life to about 16 days, and that also extends your duration of activity. When I talk about duration of activity, I mean the asparaginase levels in the blood maintain for that 21 days. So you've got 3 weeks versus your 2 weeks of activity and asparagine depletion. So then when we think about that, we think about also the structure, as I talked about in the previous slide, making it a more stable product, which means that it has a better shelf life as well. So we're now into years versus months, which is good for pharmacies. As far as the administration, we're still going to give it over 2 hours, and we're still going to give it IV. It is not indicated IM, but again, we've been giving Pegaspargase for decades IV. And its dosing is approved, and this was done through the seminal trials at 2,500 international units per meter squared for both. So there's no difference in dosing. Just to keep in mind that CalPEG, as I said, is not indicated through Health Canada in kids under 1. In the US, it is. It's indicated in kids 1 month and above. However, in Canada, they based it on the initial trials, which were done in B-cell ALL, non-infant ALL patients, but they will be utilizing the dosing of under 1 in the COG trials, and I think Health Canada will follow with an indication in Canada subsequently. So that means that we will still be using Pegaspargase in kids under 1 year, basically, in a nutshell. As far as the asparaginase activity levels go, we do measure activity levels on all of our patients, as you know. So what we would expect to see is a longer duration of activity of CalPEG. So then your asparagine, or your level, your true trough level, is probably going to be maintained beyond that 2-week period. However, because we base all of our leukemic outcomes on a 2-week asparagine depletion, we will still continue to monitor with that in mind. So we will measure at 14. We're not going to be measuring at 21. We'll be measuring at 14 days versus the 7 days that we've historically done with Pegaspargase. I will say for the induction, we will still continue to do the level on the day 1 in order to facilitate switching to Erwinia if we have to, if they completely deactivate their drug. So that keeps that option so that we can ensure that we're giving enough asparaginase in induction, that we have a interpretable MRD at the end point of that cycle. So I won't go into detail here about the infusion-related reactions or the other toxicities, because I do go into detail in the rest of the presentation. But I will say that there are differences, and really mostly that there are more toxicities with the CalPEG product. So I'll bring your eyes down to the bottom here. The funding component is it's important because it is provincially funded, the CalPEG. The Servier had managed to get provincial funding. So what that basically means, it doesn't pinch our budgets in our hospitals as much as Pegaspargase did. So that's a good thing. So this is the seminal trials that were done, and this is the care of the the Children's Oncology Group, showing the difference really in the pharmacokinetic profile and the toxicity profile of these drugs in these trials. So these were clinical trials that looked at PEG versus CalPEG. So the COG trial was the 07P4 trial, and the DFCI, you can also see that on the right here. These were the two trials. Just keep in mind that DFCI gives much more asparaginase in their protocols than we do in our COG protocols. A slight difference there. But what you can see is they were comparable. What the outcomes were with these two products were comparable in the B-cell ALL population. except that they did look, interestingly, at a lower dose. So they were looking to maybe get a license indication for 2100 versus 2500 international units per meter squared, but they showed that the MRD's positivity was higher in the kids that got less CalPEG. So that's why we're using the 2500 international unit per meter squared. They did include a few of the older patients, and I'll go into this a little bit more in a few more slides as why it's important in the older group, why we see more toxicity in that group. As far as their toxicity, they did look at grade 3-4 adverse reactions, and they saw more, or adverse events, and they saw more liver toxicity and hyperglycemia in the CalPEG group. This slide again is following on with the 07P4 COG study that looked separately at grade 1 to 4 reactions, and I will bring your attention to the allergic reactions here. As you can see with CalPEG 2500 in consolidation, the rate of reaction is listed as 27%, and for PEG 2500 about 23. So a little bit more reactions in the, not significantly higher, but a few more listed here from this seminal trial. And the DFCI trials showed about 17% incidence of allergic reactions, grade 1 to 4, which is slightly less, but likely because they give more of the product and closer together, so they don't have, the patient doesn't have time to sensitize and have that subsequent reaction. And this is just to note that this is off of the Servier website, and they show, this is from the DFCI trial, and they show pretty, and of course, you know, take this with a grain of salt because they want to show that their CalPEG product is has, you know, comparable side effect profile to their Pegaspargase. But these are grade 3 toxicities, and they list their hypersensitivity reactions as quite low here, just to keep that in mind, that it's likely much higher as we are seeing in these other trials, separate trials. So this is from the Children's Oncology Group from 1732. They did an interim analysis of their toxicity profile of CalPEG. And they looked at pancreatitis, thrombosis, and liver toxicity. And what they showed, and this is really just showing low rates in induction and consolidation with CalPEG, as you can see here in induction and consolidation, slightly more pancreatitis in the consolidation phase, as you can see here. And when they compared PEG to CalPEG, they showed no difference in any of the toxicities. All of these p-values are non-significant for the pancreatitis, thrombosis, and hepatotoxicity in induction, and also, as you can see here, in consolidation. So 1732, no difference in toxicities. The seminal trial showed more liver toxicity and higher glucose levels in the B cell population. And this is also interesting from 1732. They did show that, they did show that the older patients, as I said, did have higher rates of toxicity, as your p-values here are significant, and also the obese children ended up with more toxicity with the CalPEG. So that it really makes a lot of sense, because you know possibly your obese patient has more of a fatty liver, and what we're doing with asparaginase is as just making that situation worse. As the transport of these lipids because of the asparaginase to the liver. So just to keep in mind that these two groups are at increased risk of toxicity. And we know this too also from Pegaspargase, but just to keep that in mind as well. So this is a bit of some of you may have heard me talk about this when I reviewed the updates from PSYOP. This was presented this year by Dr. Timothy Spear from the Children's Hospital of Philadelphia. It is interesting data, and I will just bring your attention here to the VTE risk with CalPEG. So you can see that that's relatively, it's coming towards significance, verging on significance here. for higher rates of VTE in the patients receiving CalPEG. And this they then went on to tease out the T cell population and showed that they were at higher risk for pancreatitis and also VTE. It could be because they get more doses. It's not clear. And also, they do speculate that the T cell population, as that phenotype, is more predisposed to clotting, that maybe that is the reason why they saw more clots in these patients. And this slide is just to show the time to toxicity. So we're giving a drug that now has a long half-life, so we're extending that activity. So we would expect most likely to see toxicity later. And that is what they showed here. And you can see they included the B cell patients and also the T cell for both CalPEG and Pegaspargase. And really across the board, you can see that the CalPEG, most of the toxicities we're looking at around 3 weeks, if not longer. When you look at the VTE, it's quite remarkable for the CalPEG and the B cell population. They tend to have reactions. The clots tend to present almost 6 weeks after the administration of the drug. So just to keep that in mind as we move to CalPEG. So their summary basically is that they're seeing more of the VT, more clots and more pancreatitis in the T cell population. The toxicities that they saw were later in therapy, longer after the administration of the asparaginase product or CalPEG, and they speculate that the higher incidence of the clots in the T cell may be because of the T cell phenotype. So this slide is just to make sure we're all aware that the that COG protocols have allowed a dose capping of the pegylated asparaginase products, and that will be true for CalPEG as well. So for an obese patient, if they meet the requirements, then it is up to the oncologist or the prescriber to cap if they would like to cap. We have been doing that for our patients. And the reason, again, is because of the higher incidence of toxicity, especially liver toxicity in the obese patients. So this is to try to circumvent that. As long as you're monitoring levels and ensuring that you're getting enough asparaginase to the patient with your capped dose, this is permitted. This is this was reported from COG in the fall as far as what does this mean? What does CalPEG mean to patients on trials? So the FDA had a little bit of concern around extrapolating the results of the B cell ALL trials to other trials. So they are just asking for more monitoring in patients with T cell ALL and other age groups moving forward. And then for the infant ALL, I'll just briefly mention here that they are now mandating asparaginase levels for infant ALL patients, which they've never done before. And COG trials do not mandate levels. We do it as a basic good practice. But I believe they're doing this so that they can get an indication for children under 1 year for the CalPEG product. So now, what does this all mean, switching over from Pegaspargase to CalPEG? Again, keep in mind, we will still be using Pegaspargase in the kids under 1 until we can get an indication in Canada for the younger children. And then Servier hasn't committed to what this really means, but that Pegaspargase will still be available to us for these patients. When you're looking at switching over in these COG trials, the activity duration for CalPEG is 21 days versus the 14 days. So for all doses that are more than 21 days apart, it is a 1-to-1 switch, whereas those cycles of therapy, for example, induction for relapse ALL or for T cell ALL, when they're given closer than 21 days apart, the Pegaspargase, that is, we can't really switch out to 2 doses of CalPEG. So really after review, has been decided that that would be switched out to 1 dose. So instead of 2 doses in these cycles of therapy, it would be 1 dose of CalPEG. And then for the DI component, so delayed intensification has been extended to 63 days based on the longer duration of action of the CalPEG for 21 days. So it's instead of 57 days, it's now 63 days. And then when you're switching out to your short acting, so these are the patients that have reacted to your CalPEG, you're going to be thinking, how many doses do I need to give of my short acting asparaginase? And logically, you would think that you would need to give the same activity, length of activity, based on the length of activity of the pegylated product. So for CalPEG is now 21 days. So would you need to give 9 doses versus your 6 doses? Reasonable question. However, what we base our leukemic effect on is the 14 days. So it is not going to change. We are still going to be giving 6 doses based on that 14 days, irrespective of the longer duration of activity of Pegaspargase, which is good because we don't want to incur toxicity when we don't need to. And now moving into the infusion-related hypersensitivity component of these pegylated asparaginase products, which is important because, of course, when we are faced with an infusion-related reaction, we need to know if we can continue or not continue these drugs, and what this really means when we move to CalPEG, when we're seeing in reports, study reports, that there are higher incidence. And also in communication with our friends south of the border who have been using CalPEG for a number of years now, are seeing higher rates of, that may not be published, but they're seeing higher rates of infusion-related reactions. So from 1731, we would think, oh, no, it's okay. But of course, keep in mind, 1731 only gives 2 doses of Pegaspargase and now, of course, CalPEG. So we would expect lower incidence of reactivity in that patient population. Is when you get to the high-risk patients who are receiving at least 5 to 7 doses, and then your T cell is up to 9 doses of Pegaspargase or CalPEG. So from the 07P4 study, they saw about a 27% in consolidation, as I said. And again, we rarely see reactions in induction, thankfully, because the patient, again, is not sensitized to that drug at that point. And it's most likely to occur in consolidation or further cycles. The DFCI reports 17%, and then this is all that's been published for CalPEG, 3 abstracts in addition to the 2 seminal studies that report 49% and 42%. So quite different, the reporting of the infusion reactions. So the truth lies somewhere in between. For our local experience for Pegaspargase, our reactions are about 20%. And that this is irrespective of pre-medication. And now I'm going to sort of segue into how we're going to cope with potentially these higher rates of reactivity of CalPEG. What is the most reasonable approach? So we do know from our data and from, I will say, show many reports that pre-meds don't appear to work. And I'll go into that in the next few slides. Just to, the last point here to talk about our serum asparaginase level monitoring, which we will continue to do, is based on the fact that we will still be pre-medicating. It will look different, but we do not want to miss a silent inactivation. Even though we know that our rates are 0, if we pre-medicate, you run the risk of missing a subtherapeutic level that you don't anticipate because there was no clinical response. So the difference between silent inactivation and deactivation is that silent inactivation comes with no clinical symptoms, whereas deactivation, they have had a clinical reaction to the drug. So in a nutshell, we will continue to monitor levels with every dose for every patient. So this is the report from our recent chart review that spanned over about 10 years of data. So what we looked at was a pre-med group and then a non-pre-med group and a pre-med group. And we started universal pre-medication just prior to COVID when there was a universal shortage of Erwinia, and you guys will remember this. So we moved to to pre-medicating based on 2 studies that were published around that time that suggested that pre-medication was beneficial. And as you know, this pre-medication, there's a lot of pre-meds, and it can delay treatment because they forget to take their pre-med, et cetera, et cetera. So we don't want to give medication if we don't have to. And what the chart review showed was that there was no difference in the incidence of reactions, number of reactions, and severity. And also in symptoms such as rash or flushing or respiratory cardiovascular, and absolutely no difference in the patients that received pre-meds and those that did not. Keep in mind that pre-med does include an antihistamine, so cetirizine, your antipyretic, your antiemetic, and plus or minus a steroid if it was part of the leukemic treatment. So this really leads us to believe that it's not really histamine related, these reactions, these infusion related reactions, and more likely it's maybe a cytokine or complement component, in which case you would think that the steroid would be more helpful. We did see more GI symptoms with the non-pre-med group and more fevers as well. And we did see a trending towards lower rates of reactions in the patients that received steroid as part of their leukemic treatment, and that could be a support for the pathway, possible pathway of these reactions. So this is just in table format. Our chart review demographics had p-values that were non-significant. So both, there were no real differences between the pre-med group and the non-pre-med group. And as far as reaction severity, again, numbers are low, but we didn't really see a whole lot of difference in the percentage of reactions, meaning severity of reaction, except for maybe the mild reactions. But again, we had 3 versus 2 in the no pre-med group and 2 in the pre-med group. So again, really hard to determine, but it doesn't look like there's much of a difference with pre-medding as far as severity of reaction. The types of reactions that we had, you can see here that most were pretty similar from the pre-med to the no pre-med group, except for the GI. We did see a lot more of those. And again, it could be for other reasons. They get other medication. They're also anxious when they come to us. So it's possible these are the other reasons for it rather than the drug itself. The pre-med causing a reduction. And fever was also more significantly seen in the non-pre-med group. So overall, our p-value is not significant for reactions between these 2. So our story is that the pre-medication does not work to reduce neither severity or number of reactions. This is just to show the steroids did show a trend towards lower reaction in these patients that received the steroid. So what else did we learn from our data? We did not find any patient with silent inactivation, and we've been measuring levels in all patients for many years now. So that also supports the theory that it's likely not the asparagase that's is causing the reaction. So it's more likely, again, as I spoke of, the polyethylene glycol and the linker that causes the reactions. So the data that we have, we had about 15 patients that were switched to Erwinia, and of course our objective is not to switch patients to Erwinia if we don't have to. So in the pre-med group, there were less switches, so 6 out of 15 versus 9 out of 15. But keep in mind that we did desensitize a number of these patients, and that's probably why there were a lower number of switches, which is a good thing. And we were successful in 6 out of 7 of those. Well, 6 out of 7 of those patients that we've desensitized. So the number of patients that deactivated were about 8. So that's your clinical reaction and then subtherapeutic levels. So the ones that were in the pre-med group, in the patients that did not receive pre-meds, there were lower deactivations, but I wouldn't hold my hat on that because we weren't measuring levels consistently at that time. So it's possible that's why there's lower numbers there. So just to bring it together with the U.S. experience, because they've been using CalPEG now for a number of years, and what we can learn from them in sort of putting together our a practice, our general practice here is helpful. And as I said, they've been seeing a lot of allergic reactions to CalPEG more than Pegaspargase. And again, as I said previously, this is likely because of the polyethylene glycol linker component. And that, when we think about it, so the drug company itself, which was kind of interesting that they when they designed CalPEG, they wanted it to have less reactivity, but it didn't actually do that. In a sense, their objective was to hold on tightly to that asparaginase so that it wouldn't escape into the blood and cause a deactivation, a reaction and a deactivation. I think they were probably successful in doing that. However, they didn't realize that the linker with that very strong chemical bond was going to cause these reactions to an increase, quite a significant increase in these reactions. So now we have to think about, what we can do to circumvent that. We do know that the silent inactivation that was mentioned in 1731 was lower in the CalPEG group. So then that also supports the idea that they're reacting to the polyethylene glycol more so. Servier does recommend pre-meds for CalPEG. It's in their product monograph. And when I communicated and asked them for data to support pre-medication, they have none. It's not based on any data. So this, some of you may have seen as well, just reports the studies that are available. There's one more study now since this publication. So basically, 6 out of 8 studies are not supportive of pre-medications. The 2 top studies here that say yes, it did help, were the ones that were published during that Erwinia global shortage. But since then, every single study that's been published does not support that pre-medication is helpful. So now we're just going to talk a little bit about things to consider as we switch over to CalPEG, what's important, and sort of bring back what I've discussed through the presentation. So monitoring, we do want to be a little bit more mindful of longer monitoring for pancreatitis and for hyperglycemia in these patients, and this will be reflected on the chemotherapy orders. Because we would expect to see delays in presentation of these symptoms, and we need to be mindful of that. And also for just to be aware that patients can present with clots later with CalPEG up to 6 weeks. We have been seeing, I think, conclusively that there are high rates of liver toxicity in the CalPEG group, especially in, of course, those older patients and the obese patients. Just to keep in mind that we will be capping the obese patients, so hopefully that won't impact us too much. I will put a plug in here for the open COG trial for these older patients, 15 years and older, for the ACCL 1931 levocarnitine study. So that's a study looking at using levocarnitine to prevent the lipid sort of movement of lipid into the liver that is caused by the asparaginase, in order to try to prevent these toxicities in this patient population. We have not to date had a patient 15 and older that so that we could potentially offer this study to, but just to keep that in mind. And then the T cells, just to be more aware, I think it's likely that we see more toxicities in these patients because they get more Pegaspargase. But again, it may be because of the phenotype. And then we are obviously seeing higher rates of infusion reactions. So just to sort of conclude here, as far as our now standard of care for recommendations for administration of CalPEG, as our local data has shown that pre-meds don't work, and countless other studies have shown that, we are going to drop a number of these pre-meds because they don't actually change the outcome to the patient. So we will be using hydrocortisone in patients that are not receiving a steroid, so either Dex or prednisone as far as their leukemic treatment pulse. to each dose, and we will be continuing to give some Zofran as well. So hopefully the steroid will be helpful in mitigating some of these reactions if it is indeed the immune response, the cytokine response that's leading these reactions. And this is just a systematic review that was just published recently from the COG group that shows, again, and I highlighted the 6 out of 8 trials that did not show any benefit from pre-medication with both the Pegaspargase and the Calpeg. So, and we would not think that there'd be any difference in the way patients react to Calpeg versus Pegaspargase as far as the pathophysiology, as they are both polyethylene glycol products. The only difference, again, is that linker. So recommendations for administration as far as rate of infusion, this is a big one. So what I would like to do, and I think what works the best for reducing infusion-related reactions, is obviously a more dilute product and giving it over a much slower infusion time, as we see with desensitization. So like a mini desensitization, but diluting Pegaspargase every dose, Calpeg would be quite onerous for pharmacies. So what we've decided is to do a slow stepwise rate increase instead of your 20% and your 80%. And I'll show you that in a couple slides, what it's going to look like on the chemo order. But that's basically the concept, is to run it as slow as possible, because we do know with infusion-related reactions, those reactions happen within the first couple of drops into the blood. We will continue to run that fluid bolus because diluting that drug has been shown to reduce reactions as well, because less drug into the blood at one time. Obviously, you're going to see less reactions, hopefully. And then for the serum asparaginase levels, I think I've touched on this already. We will be moving from day 7 to day 14. Still continue to do the day 1 level in the induction phase. And we'll continue to obviously do levels with every dose, because we will be giving steroid. And this is the final slide just to show what it's going to look like on a chemotherapy order. So the change here, and I've underlined 4 because that used to be 3 weeks. So we will be following them for symptoms of pancreatitis, and also measure, the amount of glucose either in their urine or in their blood for 4 weeks. And then we will be measuring that level at 14 days versus that 7 days post the dose. And as you can see here, the pre-medication will include a steroid and some Zofran, and then this looks a bit more onerous, but best we could do for the stepwise approach to the administration. So it's going to be a little bit more complicated. The pumps are already, I believe, programmed for this, but we'll have to work, of course, with the outside centers. But anyway, it's going to be as little as we can over the first hour, and then the majority of the drug will be given over the second hour, and this will be done with the fluid bolus as well. And that is all I have on Calpeg today. Any questions?
When do you anticipate we will start to use it?
So I feel like I've lulled you all into a coma, but the availability, the drug is available, Krista. It's just a matter of, we have supply for Pegaspargase, and we don't want to have to, not use that and it go and expires. So it's, I guess, based on our supply. The chemotherapy orders are not quite there yet. I think they are close. So once that happens, I'm estimating by the end of the month, I'm hoping that we will be switching over. And why I'm giving the talk for APPHON next week or the week after. Yeah.
So do you remember the adults are not switching yet, right? I'm not sure what's happened with the adults. That was one of the guiding.
No, I think I've had a communication with the adults, and I believe they are moving to CalPEG. Yeah, and I've had several questions.
Yeah, no, I mean the company is going to drop PEG, so we're going to
So
have
yeah,
to switch anyways.
they are, and every time I ask them, well, drug companies are non-committal anyway. First it was like June that they were going to drop PEG from other than kids under 1, obviously in Canada, but that's what the last communication I had with Servier. But I don't know if Katon, if they gave you a date or not when you had the
No, I think they're similarly non-committal. I think they're thinking sometime early this year. That's all they would say.
Yeah. Well, it will still be have to be available in Canada. We have no choice because the indication isn't for kids under 1. So, yeah. Craig?
Tracy, I think has no. I think Craig and then Tracy.
Did you go over, I might have missed it, Tamara, that for cycles where there's 2 doses of PEG, they're going to be getting 1 dose?
Yeah, I did. Yeah. So I basically, and what it really impacts is the relapsed ALL 1821 and
T cell too, right?
So the T cell, I believe, Craig, my feeling is that David Tichy is going to drop one of those. I think that was the review in COG. So there's only going to be 1 in the upcoming trial. So then for our standard of care, I think we have to think about that as far as, and we really don't have a choice. We would need to be just dropping that out to 1 versus the 2.
The minimum space between CalPEG doses is what?
21 days.
So theoretically you could give 2, but nobody really is.
Nobody is, and also when you think about that, you could, but are you really getting full effect? And are you just, is there is no, when they reviewed it, I think the thought was, and also, when they added that extra Pegaspargase dose, I don't, from 1231, is there really any data to suggest that was better in the induction therapy anyway? Because they did a couple of changes at the same time. So I think that they took all that into account.
I mean, you have longer depletion with CalPEG, right? You got 3 weeks of much more consistent depletion compared to PEG.
So but would that make it, so as far as outcomes go, what they looked at in the seminal trial was MRD negativity and dosing of CalPEG. So there was no difference in the number of patients that were MRD negative for the B cell population for CalPEG versus Pegaspargase with 1 dose. So, but the dose of the CalPEG made a difference. It was the 2100 versus the 2500. So then that does lead us to believe that 1 dose of CalPEG is enough. Tracy?
We may have answered this anyway, after I put my hand up. But when you talked about them dropping the PEG, they can't really drop that until we've got an indication in Canada, I guess. Like we'll have
they can't. No, they can't drop it in under 1. No. Yeah. So when I brought it to their attention, they're oh yeah, because in the US 1 month, it is indicated 1 month and above. But in Canada, they went with the fact that so there's differences, and that is one of the big differences. And so I said, you realize that, and they were like, oh yeah, no, we will be providing Pegaspargase they have to for those infant ALL patients. But like I said, the upcoming infant ALL trial is going to have CalPEG in it, so they will get an indication, but it won't be, I don't think, anytime soon. But again, it's going to be confusing, Tracy, because Pegaspargase is available. Do we use it for the kids over 1? The answer is no.
Okay, and as for when we're going to do the switch, we've got 2 vials of Oncaspar on hand right now. I know we have a patient that's getting it with each cycle right now. We could finish out our supply for him or just continue using it for him until he's finished, and order it in as needed just for him and get the Asparlis on hand for anybody else. So whenever you're ready to order it, just let me know and I can get a vial or 2 on hand. And again, the shelf life is much better, so it's not such a concern.
Yeah, and we don't have to finish out patients who've started on Pegaspargase. We can switch them to CalPEG. Yeah.
Okay. So I think we'll be ready to make the switch whenever, and then we'll just make sure we get rid of whatever we have on hand.
And I think that's just based on, you know, the chemo orders being available.
Exactly.
Yeah.
Great, thanks.
Yeah. Clear as mud. Any concerns with administration from a nursing perspective? It's going to be fun.
There's going to be concerns, but probably not until the day of.
Yeah. No, I think I'm concerned about the nausea and vomiting and the more reactions, right? We'll have to kind of ongoing monitor that, and then the level piece. Right? So I think it's we'll have to see how that goes.
Yeah, and again, I mean, I just was communicating with APPHON Orgel, who was the you know, he is the one that wrote the meta-analysis, the systematic review, California, and they have dropped pre-meds altogether. It just doesn't work, and there I don't see it, and it is a concern because you say, oh, Calpec. But overall, I think, you know, again, review of our data, that there are now multiple trials saying that work. I think we just have to monitor, and if we have more reactions, we are, and I know Tracy's going to hit me, but you know, maybe we look at more at some dilution or something like that. I know it's tricky, but I do strongly believe that infusion-related reactions are related to concentration, obviously, and rate of infusion. So fingers crossed. And we are going to be giving steroids, so it'll help with fever and it will help with, you know, other parts of infusion reactions, right?
I haven't looked at
Toxicity
the
is probably the
concentration.
Yeah.
Um,
Oh, sorry, I can't hear you.
Can you hear me now?
Yeah.
Okay. I haven't looked at the allowable concentration for this. Is there ever been given any thought to just make it, like preparing it at a reduced concentration than what we actually prepare it at now? Like putting it in more fluid, not just 100 mils, versus doing all these dilutions for it to reduce the concentration. I don't know.
Yeah, I think that's an option, Tracy. I think we can start with what we have put together now, and if that doesn't work, we can become creative with diluting or diluting.
Because the desensitizations are, yeah,
are pain. No, I know.
they are very painful, I think, for everybody.
Provided that concentration works with the pump entry that was just created.
Sure. Oh, actually, yes, it very well might, because there's no standard concentration for it, but yeah,
Right.
we could look at that.
And with the higher clot risk, we're going to have to be careful with these kids with center lines.
With the PICC lines that every one of them
Especially
has.
the PICCs, yeah.
Yeah. So apixaban and levocarnitine for everyone is what I say. That was a joke, just in case anyone took me seriously. Yeah.
Sorry,
so
apixaban for what, Tamara?
I'm joking.
I thought you actually said PICCs are banned.
I think we should pre-med with apixaban and levocarnitine.
Yeah, that sounds good.
And no other pre-meds.
Yeah, and yeah. Mm-hmm.
Good luck getting apixaban for everyone.
Or anyone, Vicky.
Weirdly enough, apixaban sometimes, you know, is easier than getting rivaroxaban. In some of my patients, in the rivaroxaban request, they've asked if we've tried apixaban. So I can't keep up, but anyway.
Yes.
D-dimers for everyone?
No, absolutely not.
Or we could just work on the surgical component of the ports instead of PICC, but I know that's a different discussion altogether. But yes, it is a bit concerning. And also the liver toxicity as well. And that is something the adults are seeing a lot more of, actually, with Calpeg, from my communication with them. So. Any other questions? again, I'm going to give this talk again for APPHON for the wider community, because that is a concern for outside centers as well. And I've had a few emails already asking about, can they just order CalPEG and get rid of their PEG? Yeah, so I think that'll be helpful for them moving forward. Whether they have any questions, and I'm sure there will be. Let's think positive, right? We have no choice. Riley's is going okay. So far, so good. So let's hope for CalPEG. It is a little concerning. Also, I was in communication over the reports of desensitization of CalPEG. We had a lot of success with Pegaspargase, and there's been a couple of reports of desensitization of CalPEG, which haven't gone as well. So that's not great news. So more patients were deactivating their CalPEG during desensitization. So let's hope that's not the case. It was only a 10-patient report, but so again, that's why we don't want them to react up front, right? But again, I 100% don't think that anything we do pre-med wise is going to prevent a patient from deactivating their drug.
So, Tamara, I don't know if you can see people. Anyway, my hand's raised, but I just want to ask you. I think I was going to ask exactly the same as Ashley. I wonder if you would mind putting this talk somewhere, the slide somewhere, so we can use it as a reference, because I feel as if I'm at a stage in life where I retain something for a few days and then it's gone. So I need to get to have it as a reference would be great.
Yeah, no worries. Krista, we could put it on the Children's Health, right?
Yes.
Yeah.
I was also going to ask if you're going to update the reaction document that we have on there.
It was, yeah. It's I thought I sent you the new one. Yeah, it was updated. Yeah, I did update the monitoring and serum asparginase level monitoring document. That one?
No,
it has the reactions, like it has the table of reactions. Yeah. Mm-hmm.
Great.
Yeah. No problem. Does that work, Vicky, if it's in the Children's Health folder? Yeah. And it's free. So Krista Sweet is on here. Yeah. So CalPEG is free and Riley's is free.
It's always a nice thing.
Yeah, I would say it's party time for us, right?
At least for finance.
It's been replaced by other drugs, right? It's already been replaced by other drugs.
Yeah.
High cost drugs, that is. Yeah.
Tamara, do you know if the cost is the same as the Oncaspar?
It's a little bit more because, of course, they have to make a little bit more money, Tracy, right?
So free, but not just to the hospital. Somebody's paying for it somewhere, right?
Well, where taxpayers are still paying for it. It's just provincial. Yeah.
Okay, thanks.
Okay, well, I guess we got a couple of minutes to spare.